Thank you, David, and to Claudia for inviting me to this speak at this very interesting session. I guess I'm sort of a poser. I've had a bronchiectasis program at the University of Connecticut for only 15 years, so it's only been half of my professional life's work because I've been in practice for about 30 years. I changed the title slightly: Bronchiectasis Averting Premature Death and Morbidity by Earlier Detection. And I do have some disclosures, some consulting, clinical trial support, and some data safety monitoring committees. If I only had one slide instead of 8 minutes, this is the one I'd show. This is a new patient referred to me, had never seen a pulmonologist, for cough. This is the CAT scan result, right? This patient clearly had not been coughing for only a few weeks or a few months, maybe even not a few years. And delays in diagnosis persist. This is from Europe, where they are probably also ahead of us, if equal to, if not ahead of us in some ways in their bronchiectasis care, but from very sophisticated practitioners. And as you can see in the bottom part of this slide, the years of symptoms prior to diagnosis, only 12% had symptoms for less than a year. Most of them had symptoms for 2 years or longer. So, and I'm sure we'd see similar data in the United States if we looked. The question arises, though, do these delays matter? Clearly, there is no cure for bronchiectasis other than the rare patient who has focal disease that's severe that we can take it out surgically. And there are no FDA-approved therapies for bronchiectasis. So does it matter? I'm going to try and convince you that it does. These are data from our site. This is still to date the longest quality of life study in bronchiectasis that I'm aware of. It wasn't in a high impact journal because we only had 20-some patients, but this is improvement in quality of life from point one is when they were first visit, and then you can see that they improved. These both are above the minimally important difference on the bronchiectasis quality of life, and it persisted. And I was once asked at a meeting, what's my protocol for these patients? And I don't have one specific one. It's a very heterogeneous disease, I'm sure you know. And some patients, all they got was reassurance that they're not going to die of this. And that immediately improved their quality of life. I didn't have to do anything else. But they also got airway clearance, macrolides, et cetera, depending upon their severity. And there are worsened outcomes overall in patients with bronchiectasis, especially those with frequent exacerbations. So this looks at patients stratified based upon their exacerbation rate at baseline. You can see that the percent that was hospitalized goes up quite significantly the more exacerbations they have, and their mortality, the red line, the worst mortality are patients with more frequent exacerbations. And many of these deaths, for the cardiologists who are still here, are from cardiac events. These are older patients, so they're at risk for cardiac disease, cardiovascular disease already. And as we know, prolonged inflammation begets coronary artery disease, as does acute inflammation. And many of these deaths are shortly after exacerbations, other studies have shown. We also have other therapy, again, trying to convince you that it matters. Chronic low-dose macrolide therapy. Bottom line is it prevents exacerbations. So we use that pretty frequently, and these are 2 large RCTs that showed that. We have airway clearance that we use. There's weak evidence in favor of improved outcomes. Nonetheless, it's considered a mainstay of therapy. Inhaled antibiotics, which has been shown in meta-analyses to demonstrate significant but very limited benefit. This is an investigational compound, but I'm going to show you the data that suggests strongly that we're going to have an FDA-approved treatment within about a year. This is phase 3. And this is one of the companies I've consulted with, so full disclosure. So the phase 3 RCT was completed. It's a dipeptidyl peptidase inhibitor. It prevents activation of neutrophil serine proteases, which including neutrophil elastase, which are released in response to chronic airway infection, and the airway is the innocent bystander, is the collateral damage. And this is the top line data from this phase 3 study, which has been presented. And you can see that there's a statistically and I'll argue clinically significant decreased rate of exacerbations. This was 2 doses that were studied, and both of them worked for exacerbations. But perhaps even more exciting is the higher dose. So the purple line up top shows improved FEV1. So the delta in FEV1 in a 1-year study was significantly less. The drop in FEV1 was significantly less in placebo, in the higher dose than in the placebo and 10 milligram dose. So for the first time, we have something that prevents exacerbations and may be disease modifying, which is really the holy grail for airways disease, whether it be asthma, quite frankly, COPD, or bronchiectasis. So moving back to low-dose CT scan, hopefully having convinced you that it matters, because that's the first argument, does it make a difference? It's incredibly common. This is yet another study from Mount Sinai. So it was looking at low-dose CT in smokers, over 2,000 participants. Bronchiectasis was found in about 23%, 504 of them. The prevalence was high, obviously, and in addition, respiratory symptoms and acute events such as exacerbations, hospitalizations, were more frequent in patients detected this way who had increasing severity of bronchiectasis based upon the bronchiectasis score, radiographic score, developed again here at Sinai with David and Claudia. So this isn't just some CT finding that has no relevance. These patients are clinically sicker. This is another study from Europe looking at 855 stable COPD patients. They found 42%. These were really patients with very severe COPD. So I think that accounts for the 40 versus 20%. I mean, I am not going to stand here and say that 40% of COPD patients have clinically significant bronchiectasis. We know that isn't the case just from practicing for years. Again, it correlated with severity of bronchiectasis, exacerbations, things like that. And pneumonia was more frequent. So these are, again, clinically important findings in these patients. So moving back, I think it's the same theme we've already heard is, yes, we've found this. What are we going to do about it? And the challenge and the imperative will be to ensure that the patients in whom it's an incidental finding will then receive appropriate evaluation and treatment. I think with EHRs and prompts and things like that, it's probably not a hard lift to make sure that these patients, once they're detected, get to a pulmonologist. Radiologists can't do it on their own, but like I said, simple interventions can increase the likelihood of positive outcomes, because detection doesn't mean anything unless we actually change outcomes. Thank you.